Vanakkam. In the previous videos, we have seen when to take a decision for operating on an infant with birth brachial plexus palsy. We have also seen what is to be done, whether we should do a nerve grafting or nerve transfer in these cases. So, shall we go ahead with the surgery? Not so fast. There are a few more things to learn before we can actually understand the entire process of microsurgery in B2P2, that is birth brachial plexus palsy. Like how to explore and identify the different parts of the brachial plexus in the infant. What findings can we expect in an infant who has had a birth brachial plexus palsy? What if we find a neuroma in continuity? Should we just neuralize it or should we excise it and graft it? And if we find a root that is available, how do we confirm whether it is good enough to be a donor for our reconstruction? So, shall we see the answers to these questions first in this video? After learning about how to take a decision in birth brachial plexus palsy infants and learning about the different strategies in different situations while operating on the infants with birth brachial plexus palsy, it is now time to talk about the technical details and the intraoperative decision making in the actual surgery. This always starts with a good pre-surgical counseling of the parents, with a clear, open communication, and no guarantees can ever be given. A well-written, informed consent from the parents is absolutely essential, which must include, among other things, these 4 points. About the expected time duration of functional outcome, about the need for secondary procedure or procedures based on the outcome of the primary surgery, about the need for regular dedicated physiotherapy and mobilization, about the loss of existing function if excision and grafting is done for the neuroma in continuity if it is present. Only when the parents understand and agree to all of these, the surgery can be undertaken. The parents also need to understand that studies have shown the mean Raimondi score was 4.57 for C56 lesions, 4.26 for C567 lesions for total plexus injury patients. This is considering that the maximum Raimondi score, that is full hand function, was 5. And they also need to understand that avulsion injuries correlated with poor hand recovery. Even with the positive outcome of hand function and strength, the majority of these patients require secondary tendon transfers to further improve their situation. The choice of anesthesia is general anesthesia. We need to talk to the anesthetist and inform them that no muscle relaxant is to be used, but short-acting muscle relaxants may be used during the induction so that its effect wears off by the time the plexus gets explored. The theatre temperature should be kept raised to maintain the infant's temperature along with warming blankets to prevent thermal stress. The core temperature is regularly monitored during surgery. After anesthesia, positioning of the infant is very important. The child is placed in supine position with a slight anti-Trendelenburg tilt. The neck is turned to the unaffected side. A pillow is kept under the shoulders to allow neck extension. The arm is adducted and traction is applied in a caudal direction. This exposes the posterior triangle to open out. Once the positioning is done, the surgeon may wash up. The preparation of the following parts must be done: the involved upper limb entirely, the affected side of the neck with the shoulder, the hemi-chest up to the xiphisternum. One or both lower limbs should also be prepared. Now the incisions for access to the brachial plexus in the infant need to be marked. The first is the supraclavicular incision. This is marked by drawing a line bisecting the angle between the sternocleidomastoid muscle and the medial end of the clavicle and extending it posteriorly till the anterior border of the trapezius. This incision will facilitate exposure of the roots, the trunks, the divisions and the spinal accessory nerve, that is the 11th cranial nerve. The second part of the incision, if required, is the infraclavicular incision. This is marked by a line drawn from the superolateral limit of the supraclavicular incision following the deltopectoral groove till the coracoid, or about 2 to 3 centimeters short of the anterior axillary fold. This part of the incision facilitates exposure of the retroclavicular and infraclavicular plexus, namely the cords and branches. Making these two incisions is safe because the skin on the medial aspect becomes a medial cervicopectoral flap which is well vascularized and also affords adequate exposure. After marking the incisions, infiltration of the marked incision is important. This is done by infiltrating what is known as the stock solution as described by Dr. Thatte in his article. This is prepared by adding 1 ml of 1 in 1000 adrenaline and 1 vial of hyaluronidase in 500 ml of normal saline. This solution can be used up to a dose of 2.5 ml per kilogram. In very young infants, the adrenaline in the solution can be made up to a dilution of 1 in 1 million, that is 1 ml of adrenaline in 1 liter of normal saline to allow a dosing of 5 milliliters per kilogram. It is important to note that no local anesthetic is added since this may interfere with the intraoperative nerve stimulation that we may be using during the procedure. This solution is infiltrated in two planes, intradermal and subcutaneous, and it has the effect of reducing the bleeding and also providing excellent planes of dissection. As far as the access is concerned, clavicle osteotomy used to be performed regularly for better exposure of the retroclavicular plexus, that is the divisions and cords, especially for a postganglionic rupture scenario. Usually it is not done now because of the increased incidence of clavicle non-union and also because it became an issue in adolescents who were operated for brachial plexus in their infancy. The technique by which this clavicle osteotomy was done was by making 2 or 4 holes drilled in 2 portions of the clavicle, performing an oblique osteotomy between the holes, retracting the cut ends of the clavicle to afford good exposure of the plexus, and then reapproximating the clavicle by thick absorbable sutures passed through the holes. Because of the reasons already mentioned, this procedure is usually not preferred now. Instead, excision of the subclavius muscle is done from the undersurface of the clavicle and passive shoulder motion can be done to bring the nerves above and below into view. But to make this possible, all the soft tissues between the clavicle and the plexus should be divided. For a detailed description of the exposure of the plexus, you can refer to my previous video which you can access by clicking on the icon above. The salient points are dissection through the platysma and supraclavicular fascia to the plexus. The omohyoid muscle and the transverse cervical artery need to be transected. The phrenic nerve needs to be identified, which can be seen on the anterior surface of the anterior scalene muscle. It may be associated with scarring. This can be followed cephalad to the C5 root. The C5, C6 and C7 roots are sequentially exposed between the anterior and middle scalene muscles and labeled with silastic loops. Generally, the upper roots are intact and there is an extraforaminal neuroma at the junction where the C5 and C6 roots form the upper trunk, otherwise known as the Erb's point. Then, sequentially, the suprascapular nerve should be exposed and labeled with a silastic loop. The musculocutaneous nerve is identified and labeled. The radial and axillary nerves are exposed and dissected. The posterior division of the lower trunk should also be identified. This is generally intact in upper plexus lesions, the posterior division of the upper trunk and at times the middle trunk should also be dissected, but they are usually encased in the neuroma. The pathology of the plexus that we may find on exploration will be one of these three possible findings: rupture, avulsion, or a neuroma in continuity. Rupture refers to postganglionic injury to the nerve, that is neurotmesis, where there is separation of the proximal and distal ends and the gap being bridged by scar tissue. As far as rupture is concerned, the important point is how to assess the proximal stump, whether it is good as a donor. Avulsion is a preganglionic lesion with the avulsed ganglia seen in the neck and may be associated with pseudomeningoceles. Typically, the foramina will be empty. In case we find an avulsion injury, we will have to examine the other roots also. Once that is done, we can go ahead with reconstruction according to the planned strategy. The third possible finding is a neuroma in continuity. This is a postganglionic rupture, but it has healed with fibrosis and some axons traverse the scar tissue. This neuroma in continuity may be conducting or non-conducting. Since some axons may be conducting in this neuroma in continuity, it presents a dilemma. Should we do a neurolysis and stop the procedure, or should we excise the neuroma and reconstruct all the parts of the plexus? So it boils down to two basic questions that we need to answer before we proceed: how to assess the proximal stump and how to decide whether to neuralize or resect and graft a neuroma in continuity. Let us first address the problem of how to assess the proximal stump. This can be done by one of the following methods: microscopic examination, frozen section study, intraoperative neurophysiology studies, or other methods. By microscopic examination we mean cutting the proximal stump in slices, or what is known as a bread loafing technique, till we are able to see good fascicular components. This is preferably done under an operating microscope, and a finding like this showing multiple fascicles with good bleeding from in between them will suggest that it is healthy and can be used as a donor. If there is still a doubt and facilities are available, frozen section staining can be done by cryostat sections, hematoxylin eosin staining, and toluidine blue staining to validate structural details. Intraneural fibrosis can be traced safely with both staining methods. For more proximal intraforaminal lesions, semi-thin sections stained with toluidine blue are less informative than hematoxylin eosin stained cryostat sections. One particular study assessed the quality of stumps assessed histologically and its correlation with the strength attained in the target muscle. Both histopathological and morphometric examination showed a reduction of the quantity of myelin. The amount of myelin is significantly correlated with muscle function after nerve grafting. So what is important is the assessment of the quantity of myelin by intraoperative examination of frozen sections. The second point to note is the fibrosis rate. Patients with a lower fibrosis rate for the suprascapular nerve had a greater global Mallet score as well as greater active shoulder flexion. The next modality of intraoperative assessment of the proximal stump is intraoperative neurophysiology. Generally, intraoperative nerve stimulation can be used to judge the nature of the neuroma, to assess the intact roots by somatic evoked potentials or somatosensory evoked potentials from a reasonable looking root stump to ensure proximal continuity, and also to identify and confirm donor nerves such as the spinal accessory nerve, the ulnar nerve, and the median nerves. Intraoperative nerve stimulation of the neuroma in continuity can be done and the motor response obtained can be assessed. As far as sensory evoked potentials were concerned, one particular study said that both root evolved somatosensory evoked potentials and root recorded motor evoked potentials inherently have low signal to noise ratio, that is, signal amplitude on the order of few microvolts only, making it challenging to obtain a reliable intraoperative recording. In addition, muscle artifacts, electrical noise, anesthetic effects, poor electrode contact with neural tissue, and current shunting in a wet surgical environment interfere with successful signal acquisition. Recently, the use of other methods like the ultra high frequency ultrasound have been used as a reliable tool to directly visualize nerve injury both preoperatively and intraoperatively. Now we come to the dilemma of the neuroma in continuity. The option of dissecting through the neuroma to find out intact fascicles and protecting them is a tedious and potentially damaging dissection, and it is better avoided. So what can be done in this situation of encountering a neuroma in continuity? Just neurolysis or resection and grafting of the entire neuroma. We should remember that whatever we do and the choice of microsurgical technique should be based on the whole clinical and intraoperative view. To help us take a decision, let us see some studies that have been done on the advantages of neurolysis and the advantages of excision and grafting. A study in 2011 says best results after neurolysis should be expected when neuroma in continuity is located in the upper trunk, the injury corresponds to third degree on Sunderland scale, and during electric stimulation, a normal motor response can be obtained. Another study from 2014 says there is a subgroup of patients who can benefit clinically with functional improvement of shoulder and elbow function from treatment with neurolysis alone for upper trunk lesions, demonstrating more than 50% conduction across the neuroma on intraoperative nerve testing. Patients with less than 50% conduction indicating more severe disease are treated with nerve resection and grafting in the author's treatment algorithm. As a response to this article, Pondag responded in a letter to the editor saying, "This procedure needs to be labeled as neurolysis and it is a diagnostic procedure. The recovery that subsequently takes place is the logical result of completing axonal outgrowth through the damaged area to which neurolysis did not contribute." Being against neurolysis, Gilbert indicated the necessity of resection of each neuroma in continuity during the operation performed in the third month of life. This he felt should be done to avoid the worsening of motor function of the limb, which is observed after surgery conducted at a later date. Curtis and Clark were more categorical, who after their study in 2009 said that neurolysis alone has no role. Capek et al. Compared the results of treatment after applying the two surgical techniques, that is, resection and graft or neurolysis. In the group in which the reconstruction was performed, deterioration of upper limb function during the first 6 weeks of operation was noted. After 6 months, the condition reached preoperative level, and after 12 months, clinical improvement was obtained. And during the period of 12 months observation, the improvement of function did not differ in both groups. Dr. Tatte's via media approach is to base the decision on preoperative clinical findings of muscle function, particularly the deltoid. And secondly, an intraoperative stimulation of the neuroma in continuity needs to be done. If the neuroma is conducting and results in shoulder abduction and visible deltoid contraction, isolated Oberlin transfer for biceps and spinal accessory nerve transfer to the suprascapular nerve can be done. If on intraoperative stimulation of the neuroma in continuity is weakly conducting or non-conducting, excision of the neuroma and grafting is ideal. But we need to remember that preoperatively we should have got a consent for this. So far, we have been doing an exploration and taking decisions as and when we saw the structures and the findings. But exploration is complete only when we have dissected all the available routes and confirmed their viability and functionality. We have decided what to do with the neuroma in continuity, whether it's going to be neurolysis or excision and grafting, and we have dissected the possible donor nerves and confirmed their viability and functionality. So now we are ready for the reconstruction or the actual microsurgery step. This step actually refers to the nerve coaptation, whether it is a nerve graft or a nerve transfer. If it is a nerve graft, it is done as follows. We need to measure the defect between the proximal and distal stumps, and we need to calculate the number of cables required for all the distal targets and arrive at the total graft length required. For example, if 12 cables of 2.5 centimeters are required, then we need 30 centimeters nerve graft, which will mean one sural nerve graft plus medial cutaneous nerve of the forearm plus the superficial radial nerve. These grafts are made into bundles and both ends glued together with fibrin glue. The central 4/5 is not glued to allow ingress from neoangiogenesis. Epidural suturing is the commonest technique followed. Here, the graft bundle is coapted to both stumps with 2 or 3 sutures of 9-0 or 10-0 nylon. The union is strengthened by fibrin glue. It is important that the neck, shoulder and arm must be moved passively to do a stress test on the coaptation. And the nerve coaptation is always done with the shoulder pulled inferiorly. The problems arise when there is a paucity of available nerve autografts. In such situations, different types of nerve conduits can be used. You can click on the link above to see more details about these nerve conduits. But they are not proven to be as or more effective than a nerve autograft. Similarly, nerve allografts have also been introduced that have served as an adjunct to nerve autografts for brachial plexus reconstructions. They can be used to bypass neuromas successfully in reconstruction cases with conducting neuromas. In addition, once the allografts and autografts have been sutured into position, another product made from porcine small intestine submucosa known as Axoguard has been shown to decrease epidural scarring and remodels into similar epinurium and facilitates revascularization around the surgically repaired brachial plexus. These nerve axoguards are wrapped around the roots, trunks, divisions and branches, securing the brachial plexus and the nerve grafts that have been applied. The commonly used post-operative protocol is a bulky dressing with the arm strapped to the chest. The infant's shoulder is immobilized by strapping his arm to the body to minimize unnecessary movement. Different types of immobilization have been tried, like a cocoon, to reduce the movements of the neck also, but these are quite cumbersome. The wound is inspected weekly and removal of sutures done on the 10th post-operative day. Strapping is then reapplied and kept on for a total of 4 weeks. Mobilization is started 4 weeks after surgery, which includes passive abduction, external rotation and flexion exercise of the shoulder and passive pronosupination exercises for the forearm. After 4 more weeks, full passive mobilization program is instituted. Some complications can occur as a result of this microsurgical procedure on the infant with birth brachial plexus palsy. Complications secondary to infection, bleeding or worsening neural condition are rare. At times, a phrenic nerve palsy and an elevated hemidiaphragm can occur with microsurgery. The clinical scenario is difficulty in feeding, not true respiratory depression. This is usually the result of mobilization and traction on the phrenic nerve and resolves with time. However, if it persists and affects respiratory function, a late diaphragmatic plication procedure is appropriate. Non-union of a clavicular osteotomy leads to chronic pain and decreased function until rectified by internal fixation and possibly bone grafting. But perhaps the major complication is failure to achieve the desired outcome in the birth brachial plexus palsy. If there is failure of any recovery at 6 to 12 months post-operatively, observation will not improve the function. Either re-exploration and further nerve reconstruction or secondary regional tendon or free muscle transfers are warranted in such a situation. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about clinical features in birth brachial plexus palsy and the different investigations that can be done in this condition. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.